All right. Good afternoon, everyone. Thank you for joining us. My name is Danae Aber. I'm the Executive Director of the Louisiana Rural Health Association. And again, thank you for joining us for this webinar titled, Can I Do That in My RHC? LRHA is happy to host this webinar presented by Inquisite Consulting. This webinar is being recorded and will be available along with a copy of the slides on the webinar recordings page of our website. And I will drop a direct link to the relevant page in the chat. You're muted so we can prevent background noise. If you have any questions, you can pop them into the chat box or into the Q&A box, and we will try to address those throughout the webinar. After the webinar, a survey will automatically open in your internet browser, and we do ask that you please complete that survey. It helps us to continue to improve for future events and identify future education topics that'll be valuable to you. And with that, I'd like to welcome Ms. Patty Harper. Patty is the principal of Inquisite Consulting. She has over 26 years of healthcare experience in the areas of healthcare finance and reimbursement, health information management, compliance, and practice management. She holds a BS in Health Information Administration from Louisiana Tech University and is a frequent speaker and content contributor for national, state, and regional organizations on these topics and other rural health topics. She's a great partner of ours. She speaks at a lot of our events and is very gracious to do lots of educational webinars and content for us. So thank you so much, Patty, for being here, and I'll hand it off to you.
Thank you, Danae. I'm really can't believe everybody's getting on a webinar this close to Christmas, but this is really a hot topic right now. And so we just want to go over a few things. So we're going to talk about RHC services versus non-RHC services. So, and I'm not going to get ahead of myself, which I typically do, but some of the things that are very popular cash pay services right now actually fall in the category of non-RHC services. And so we're going to talk about why that can be a problem and the best way to handle those things. I'm also going to talk about some other things that are related to that. And if we have time, I'm going to end up talking a little bit about incident to billing and the use of locums in an RHC. So we have a lot of content. So first of all,
I'm sorry.
these are some of the
These are some sharing your screen.
I'm not sharing. Okay, what is the problem? Okay. Okay. Okay, Danae, what about now?
Perfect.
Okay, perfect. Sorry, guys. I was already complaining that I can't get these double screens to do what they're supposed to. So this is kind of what we're going to talk about is RHC services versus non-RHC services and some of the things that can be problematic. Okay, so these are some of the things that give us a little bit of concern in rural health clinics. So we're going to talk about some of these. I'm not going to tell you that you absolutely cannot do something in your rural health clinic. I'm going to tell you why it can be a problem and the best way to do some of these things. These are very popular self-pay, cash pay services right now. I know everybody is looking for something that is a good new revenue stream. So again, I'm not going to tell you that we can't do any of these ever, but I'm going to talk about why some of them can be problematic. Bioidentical hormones are extremely popular. A lot of clinicians are very convinced about their efficacy. I'm not challenging that. It's just not something that is approved by CMS or the FDA, so it's considered investigative and experimental. We're going to talk about supplements and vitamins, things that you might sell that go along with some of these services, whether it's ideal protein, whether it's vitamin supplements, medical aesthetics in a rural health clinic, along with other spa services like massage, Some of those can be problematic. Something that's really coming up now are, I call them the bougie infusions, but they're like detox infusions, things that, you might give patients that, it's not the same thing that we would do with a stomach virus or something like that. And so where this becomes to be really important is in our Medicare policy benefit manual for the RHC. So if something is not, so certain services, I'm reading straight from the screen, I don't like to do that. Certain services that are not considered RHC services are either because they are not included in the RHC benefit or they are not a Medicare benefit. So remember, as a rural health clinic, you are a CMS certified. In Louisiana, you are a licensed facility. So you're not a normal medical practice. This is not your own medical practice. You become a certified and licensed facility. And so the services that we do are considered non-RHC services if there's something that Medicare or Medicaid would not recognize as a benefit. So we're going to talk about, I know exactly what you're thinking, and we're going to get there in a minute. And so there are things that are statutorily excluded from Medicare in a general sense, and those are routine physical checkups, dental, and eye exams that are not related to some kind of underlying disease or screening. So that this is why I don't want you to put that somebody's coming in for their annual checkup, because Medicare has never, ever, ever covered an annual checkup. And so sometimes our wording can be really important when we put that chief complaint in. So the statutorily excluded services are also things like cosmetic procedures. And believe it or not, CMS in 1964, when the Social Security Act was created, considered weight loss cosmetic. And so we are going to talk about the exception to weight loss being covered is only through our intensive obesity counseling, which is a preventive service for Medicare patients. Anything else that is just promoting weight loss is not typically covered. So we have to be very careful as an RHC that we are not advertising that we are running a weight loss clinic. You are only one kind of clinic, and that is a rural health clinic. And so we need to be very careful about how we hold ourselves out. Surveyors, both at the state level and with your accreditors, check your website. They check your social media to see how you're representing yourself to the public. So they're going to be very curious about some of these things that are not RHC services when we're doing them. If something is experimental or investigative, then that is not going to be an RHC service because it's not going to be covered by Medicare or Medicaid. Also, anything that is not medically necessary, according to the local and national coverage determinations, is also not an RHC service. Personal care services, some of the things that we would consider like spa services and retail sales of supplements and other products. So these are the things that we have to be very careful about. Again, I'm not going to tell you that you can't do any of these, but we're going to talk about why they can be problematic. But before we do that, I am going to go through, this is new content if you've heard this conversation before. I'm going to go through the only exception for weight loss. The only exception for weight loss is the preventative service, CMS's intensive obesity counseling. And so I want everybody to pay close attention because I don't want you to start using this code and use it inappropriately. So we do have a national coverage determination. So this is when CMS lets us know the criteria for a service. It also will let us know certain codes that apply to the service. And so we do have G0447 G0447. Sounds like I'm calling bingo. And that is a face-to-face behavioral counseling for obesity, 15 minutes. This is a qualified rural health clinic preventive service. So this is the only thing that Medicare covers related to any kind of obesity, weight loss, diet program. And so there is also a group code that's in this NCD, but we cannot do group counseling in an RHC environment. Now, counseling here is not meaning behavioral health counseling. This counseling has to be done by the primary care provider. And so that is listed down under the coverage bullets down here. Medicare will cover up to 22 visits billed under this G0447 when we meet all the criteria and we document all those visits correctly in a way that satisfies that we've met the coverage criteria. Here's the same thing, just in another view. It's also referencing the national coverage determination. Now, again, I want you to realize this is a structured preventive service. This is not a code that we are just going to throw around. We have to do certain things to use this preventive service, to bill for this preventive service. We have to assess, advise, agree, assist, and arrange. I have a graphic that's probably a little bit easier to understand than this, but it will allow one face-to-face every week the first month, then a face-to-face every other week for the next 4 months, and then monthly visits until we have met those limit of 22 visits. So I'm going to go through the elements of this preventive service. And this is the only exception to us having an RHC service, that is covered by Medicare. I want to be clear on this. We have to assess, so there has to be a BMI measurement greater than 30. We have to find out about the patient's nutrition. This might be a place where we also find out something about social determinants of health. The patient has to be competent and aware, engaged, and motivated for us to initiate these visits. So I'm not going to be able to do this for my nursing home patient, probably, or somebody that's not able to collaborate with me to do this. Then we're going to advise. There has to be a personalized care, when I spelled personalized care plan, counseling, therapy, social support. This is again provided by the primary provider, and some of it anyway, it has to be documented, and it has to include diet and exercise. So it's a multi-dimensional plan for this. The patient and the provider have to agree on the treatment plan. They have to agree on how the weight loss is going to be achieved and what methods of weight loss are going to be used, and that has to be documented. And then we're going to assist the patient through these visits to help coach them, to provide materials for them on diet, exercise, nutrition. We are allowed to use medications, adjunct medications. So not all of our weight loss drugs right now are covered by Medicare, and maybe our patient will qualify for one of the diabetes drugs because of other health conditions they have going on. So we are allowed to use medication, but the medications we use may not be covered, and we may be using them off label. And so this is a place where we probably could use the current weight loss drugs, but we're going to have to be careful how we do that. And then we have to schedule follow-up phone calls. This preventive service, these visits are eligible for telehealth. And then we're going to adjust the treatment plan as we go along and make outside referrals for other services. So we do have frequency limits on this. It's possible that your patient has seen somebody else and they've already used this benefit up for the calendar year, or they have used part of those visits up. So we're going to always want to verify that coverage. So initially, we are going to have the face-to-face visit with the qualifying provider, up to 22 visits a year, and no group therapy in RHCs. We can do no group therapy in RHCs for anything. It's just goes to our definition of an encounter, which is a one-to-one face-to-face visit between a patient and a provider. So in the first month, we can have weekly visits, and then we can have every other week visits for the next 4 months. All of this has to be documented and tied back to the care plan that has been individually created for that patient. At 6 months, the patient has to be reassessed. If that patient has lost, I don't know where they came up with this, 6.6 pounds. Danae, do we have a question?
Yes, we do. Are the obesity counseling services limited to certain providers? For example, can a registered dietitian perform this?
So if we go back to the national coverage determination, it says that this counseling has to be by the primary care provider. So dietitians are not, we can't pay, we cannot separately bill for dietitian services in a rural health clinic for Medicare or Medicaid. So they could be support staff and they could add to those services, but a meeting with a dietitian would not be a standalone visit unless there was a primary provider involved in that visit also. Okay. All right. So after 6 months, if I've lost 6.6 pounds, then I'm eligible to finish the rest of the 6 months with the service. If I have not lost the weight, then I have to reassess, and then I have to wait 6 more months before I can try the counseling with the patient again. And all that would be documented. So if the patient has made progress, 6.6 pounds, not sure where that came in, then I can keep performing the services on a monthly visit. And then after 12 months, I should be through with that patient. At 12 months, if we had to stop at 6 months because they weren't progressing, then the clock starts over for that patient. Okay. All right. So this is new content for me, and I think you will be able to use it for some of your patients. But like I said, we don't want to be careless. Okay, Danae, what's going on?
Yeah. Can an APP do the weekly or monthly visits?
So our qualified RHC providers are physicians, nurse practitioners, physician assistants, certified nurse midwives. Those are our qualified providers. So any of those qualified providers. In a rural health clinic, there is no distinction between physicians and advanced practice providers. Everybody is a qualified provider and is paid for an encounter. So if you're new to RHCs, then it doesn't matter which type of provider, as long as they're a qualified rural health clinic provider does a service. So most certainly, we would have, we can have our advanced practice providers in that. We do want to make sure and check through Novitas to make sure that that patient hasn't exhausted those visits yet, that benefit yet. Okay, so what we have just talked about is the only time that Medicare considers any kind of obesity treatment medically necessary, and it's as a qualified preventive service, right? So what happens if the service does not meet medical necessity? Or if there's a service that would not be a Medicare or Medicaid benefit, what then? And so this is where we have to understand RHC reimbursement. We have to understand RHC cost reporting. I peeked, and I know that we have some cost report preparers on this call, so I welcome you to jump in, to clarify, to make a correction if I misspeak on this. So what if the patient pays cash? I hear this all the time, but the patient is paying cash. The patient is paying cash. I'm not filing a claim to anybody. You know what? That doesn't matter. It doesn't matter who's paying for the service. It matters how we're dealing with the direct expenses related to those services and how we are using licensed space and how we are using certified space. So whether the patient pays cash or not is not really the issue. The issue is, as cost-based reimbursed clinics, we have to be concerned about being able to separate our expenses between RHC and non-RHC services. So if we don't understand that that is how our rate is calculated, we don't understand that we have to keep it separate. So this is where I'm saying, I'm not saying you can't do it, but we may have to separate it. We may have to separate it between the hours that the services are performed. We may have to separate it by adding additional bookkeeping processes in place. But I just want you to understand this. Just because the patient is paying cash doesn't really matter in a rural health clinic, because it's not the fact that we're not filing a claim. The problem is, what are we doing with the cost? What are we doing with the direct expenses? Because that goes into how we're paid. So that's really the issue. So I know y'all didn't really want to hear that, but it's very important. So when your Medicare rate is calculated every year, it is your allowable cost, which are your direct expenses, the things that you have to pay to keep your practice going, divided by the number of qualified RHC encounters. That's how our rate is calculated. So I have to keep all my allowable expenses in one bucket and all my non-allowable cost or expenses in another bucket, because I can't include the non-allowable, the cost of doing the non-allowable services can't be in my rate calculation. So that's where our problem is. It's a RHC program and accounting and cost reporting problem, because what we're going to do is our total direct cost less our non-allowable cost. So we're going to have to take out everything that deals with one of those non-RHC services. It's going to have to come out. The visits that are attributed to the non-RHC service also have to come out. Now, I'm terribly oversimplifying this, but I'm bad about getting in the weeds, and I didn't really want to get in the weeds too much on this. Cost report folks that I love and appreciate, if you want to jump in on any of this, you're welcome to. So that is our problem, is we can't include the visits or the cost of those non-RHC services being things that don't go in our rate calculation, things that are not a Medicare or Medicaid benefit or are not a rural health clinic benefit. So that's where our problem is. So again, it's remembering that you have a certified, and in Louisiana, a licensed facility. You are no longer a medical office. You become a medical facility. And so that changes how we perform services, where we perform services, and when we perform services. Where, when, and how. And so that is our issue. So our problem gets to be, what if this is my clinic and I have somebody with an injury, somebody with chronic follow-up, somebody's having an annual wellness visit, somebody's having Botox, and somebody else is having a massage, and everybody is in all these rooms. My same nursing staff is working all these rooms. I'm getting supplies out of the same closet. I'm getting medications out of the same closet, and it is all mixed up. how in the world am I going to be able to justify that I took out the direct cost related to those non-RHC services? It's going to be almost impossible to do that. And so that's where we get into a problem. In Louisiana, we also get into a problem because we cannot have licensed and unlicensed services in licensed space. So we also have to think about, are we using our rural health clinic in the way that we were licensed and certified to use it? And so that is particularly an issue in Louisiana. A lot of times there's something that we can do on the CMS side that we cannot do in Louisiana. So before you start any new service, before you buy everything for something, before you hire somebody to do something, check with your consultant or check with your cost report preparer and just say, hey, we're thinking about doing this. And can you see any red flags? Is there anything that I need to consider? Anything we need to do differently for this service? Is it even something that I can do? If I can do it, how do I do it correctly? And so this is where we get in trouble. I can't have all of these different activities going on in the same clinic with the same staff, using the same supplies, and be able to have accurate cost reporting. And then for Louisiana, I may not be using my license space correctly if I add some of these services. So those are the issues. And that's what I just said is, how are we going to separate the RHC from the non-RHC visits and cost if everything is all mixed up together? That is our problem. Our problem is not how we're getting paid. Our problem is, how are we going to report all of this activity correctly and make sure that we've separated the non-RHC and the RHC services for cost reporting? Because if we don't do that, we could overinflate our RHC rate using the cost for services that were never RHC services to begin with. And that would be very problematic and could cause our Medicare contractor to question our cost reporting methodologies and everything else. Looks like we might have another question. No. Okay, I'm going to go on until Danae pops up and tells me we have a question. Oh, there she is.
There I am. So the question, it's from Kate. So she says, how do we properly carve out a room for specialist who comes into town once a week and does not want to bill through the RHC?
Gee, I think that I have a slide if we'll just hold on and to get there. I love this. This has become such an issue too. So these are some of the things that we have to carve out. Again, you are going to want your cost reporter to be right by your side when you do this to help you know what you're supposed to do and what you're not supposed to do. So these are some of the things that we have to carve out. Okay. And again, I'm oversimplifying this, and I know that you're not all accountants. So some of these words like direct cost and indirect cost and those kind of things may not mean anything to you. That's why you really need professionals in your back pocket to help you navigate some of this. We would much rather, I'm going to speak for me and probably for John Wells and some other people who are on this call, we would much rather we get the phone call before you start doing something than you call us right before the end of the year and say, hey, oh, by the way, I started doing medical aesthetics in my RHC. What was that okay? We'd much rather you ask us on the front end. Danae, we have another question.
Yeah, circling back to the obesity counseling, you said that it was a once a lifetime benefit once they used 22 visits. So was it 22 visits for the lifetime?
It's 22 visits a year.
A year.
But if they've successfully completed the counseling, so this is going to be something that you would follow up with every year when they have their annual wellness visit, that you would monitor that BMI. And also when we are reporting that obesity training, obesity counseling, we also want to make sure that we're including the Z code for the correct BMI. Most EHRs is capturing that automatically. So good question though. It's in that national coverage determination, which I can I can send out a link for that when we're done. Okay. So again, just make sure you're looping your consultant or your cost report preparer in so that you know what you're doing. Now, there are all shades of gray. When I taught on this at NARC a couple of years ago, I called all the cost report people that I knew nationally, locally, regionally, and they all had varying degrees of when they thought something needed to be carved out and when they thought that it didn't. And so that's why, again, I'm not going to tell you you absolutely cannot do anything, but you need to ask and get everything in place before you start doing it. You may have to add new general ledger accounts. Some consultants are going to tell you to have a medical spa in a separate building under a separate tax ID number. Some are going to say it's okay to do it on Saturday morning. So you're going to get different answers. Just make sure that your trusted partner is looped in on your decision making at the first. We had a clinic in Texas, and the clinic manager went on vacation for 2 weeks. And when she came back, the parking lot was full of all of these flags advertising Botox and fillers and stuff. So the providers had gotten together while she was gone and decided to implement a new service. So that's not how we want to do it, because there's a lot more to be considered, as you can tell. We need to be really careful about marketing and advertising. And we're not, and so I'm going to talk a little bit more about that later. Having non-RHC hours is probably the cleanest way to do some of these services, because then you can get your hands around the staffing cost on that day. You can put the supplies in a different closet, and you know what supplies we used, and you're going to charge those to a different QuickBooks account. Those are probably the easiest way to do some of these. Do you have adequate training for some of these? So, you know, you can go and learn Botox on a 12-hour weekend course. So that's not very long to learn where I want to inject that stuff and where I don't want to inject it. But you certainly can be certified for that, or get some kind of training to do that over the weekend for 12 hours. I'm one of those nerds that reads the Medscape cases to solve. And one of them was a woman who suddenly went blind in one of her eyes, only to discover that the week before she had a Botox injection on her 11s, I think that's what they call it, and that Botox had infiltrated her optic nerve, and she was blind. So those kind of things can happen. And we want to be careful about marketing and advertising. Our marketing people, they are so creative. They are so clever. I just had a meeting with our marketing team this morning on something. You know, I don't have that skill set, but they don't have the regulatory compliance background, and they don't have the medical background. So sometimes they will change a word up, something that's snappier or jazzier. So you need to make sure that marketing is not advertising your RHC as a weight loss clinic. Again, we don't have clinics within a clinic. You have services within a clinic. Those services can be RHC services or non-RHC services, but we don't have clinics within a clinic. Just like we don't have a walk-in clinic, we have walk-in hours. So we need to be very careful that marketing runs something by somebody in compliance before. We can have different hours and different appointment types for different services that we can have. And some of these things, like medical aesthetics, would be better done during non-RHC hours, when we can totally separate ourselves from the RHC. We had a question yesterday or the day before yesterday: can only part of my RHC have non-RHC hours? And I said, no, I don't know how you would allocate those costs. I'm not sure how you would do that. Either your RHC is operating as an RHC or it is not operating as an RHC. I can't have one provider doing non-RHC services during regular RHC hours. And I know that from a licensure perspective, that LDH would probably agree with me on that. We need clinical documentation. I'm getting to the specialist, I promise. Some of these services, particularly some of the bioidentical hormones, part of the medical record and part of the test results are kept in that supplier's cloud and not in the full integrated medical record of the clinic. So we have had situations where somebody had a hormone implant. It was not in their regular medical record. They ended up having to go to the ER for an infected site. And there was absolutely no record of that patient having that service in their integrated medical record because part of that record was on BioT's cloud. I think BioT has renamed themselves. So just make sure that we have complete documentation for everything that we do, even if it's a non-RHC service. Sometimes these vendors will advertise where you can get their services and they won't be representing your clinic correctly. They'll be advertising one of your providers instead of your clinic. Again, you are a healthcare facility. Okay. If you're ordering, receiving, and administering off-label or compounded drugs, are we handling those appropriately? And are we separating the cost of some of those drugs correctly for cost purposes? I think you're probably better to have to write a script and have that patient get those compounded drugs rather than you having to manage that inventory and have the patient come back in for that injection. And again, are we handling cash only? This is a big deal. If we are selling supplements, personal care items, diet foods, how are we handling sales tax? So in Louisiana, over-the-counter medicines and dietary supplements are taxable. And so we need to make sure that if we are selling something that we are correctly taking care of any sales tax that would be due for those products. I've been in RHCs where they're selling Mary Kay or they're selling essential oils. So these would be products, again, that we're not in the business of selling things. We're in the business of providing primary care services and medical services. So if I'm selling something, those costs have to come out of the cost report as well. Okay. This top bullet talks about productivity standard. Productivity standards are going away in 2025 for people whose fiscal year ends at the end of December. If your fiscal year is somewhere else in the, doesn't fall with the calendar year, you're going to wait one more cost report cycle before the productivity standards go away. And so the basic thing to remember is if it is something I'm not getting paid my rate for, like medical telehealth on the Medicare side or care management services, which are also changing tremendously this year, anything that doesn't pay my rate isn't a visit on my cost report. And so that's just a very easy way to remember that. RHC versus non-RHC hours, I've already talked a little bit about this. You can designate non-RHC hours. And these are hours that you are not operating as a rural health clinic. In Louisiana, up until September, we were required to operate a minimum of 32 hours a week. Now, Louisiana, we don't have minimum hours. However, we still have to go by our posted patient care hours. And so anything that is not done during RHC hours, those direct costs would be removed from our cost report. Those visits would be removed from our cost report. And services are billed as a fee for service during non-RHC hours. So your system also has to be able to toggle back and forth between when you're billing that institutional claim for Medicare and when you would be billing a fee for service on a $1,500 for Medicare. So it's very complicated. You have to make sure your system is going to be able to switch back and forth. We don't want to look like Swiss cheese. We don't want to be non-RHC from 7:30 to 9 in the morning, and then we're RHC from 9 until 4, and then from 4 until 5:30 we're non-RHC again. We don't want it to be all piecey like that, again, because we're not going to be able to accurately keep up with the difference between cost related to RHC and non-RHC services. So here would be an example of how we would post our hours. We would have non-RHC hours posted. And there's a clear, definite time when we're switching between RHC and non-RHC. For your Medicare patients, say you were having non-RHC for some procedure that doesn't reimburse very well or shouldn't be done as an RHC service, then your coinsurance calculation is different for your RHC visits versus your non-RHC visits. And so your patients could get confused on their coinsurance amounts because they're going to be very different, calculated very differently. Treatment rooms. When I first got into this business about 15 years ago, treatment rooms were very popular. We had that one exam room at the end of the hall, and it was like, this is not the RHC. You are in some suspended place in time and space, and if anything done in this room can be billed however we want to. In the Benefit Policy Manual, Chapter 13, it's very clear that we cannot have a treatment room. Now, a treatment room does not mean a procedure room. Treatment room is the RHC jargon that we've had for years about a room that is exempt from being an RHC. So it's not going to say, last time we did this, I had all these phone calls. Well, can I not have a procedure room? That's not what we're talking about. We're talking about a space in your clinic that magically becomes something else. And historically, it's been called a treatment room with air quotes on it. But it does not mean that you cannot have a procedure room. I just can't have that special room that anything in there all of a sudden is not an RHC service. That's what it means by treatment room. So when I put this up, everybody said, can I have a procedure room? Yes, you can have a procedure room, but you cannot designate a room to magically not be part of the RHC and let you bill any way that you want to while you're in there. That is prohibited. Physical separation of space, we already talked about that. We have to be very careful about also co-locating and co-mingling. And so if we are in a building, now notice around this red block, if we are in a building, not our clinic space, not our licensed space, but we're in a building with another entity, the RHC space has to be clearly defined. And if we lease a space, it has to be carved out of the cost report. You're not going to want to lease space without, again, clearing it with your cost report preparer. And I'm very conservative on this. Your cost report preparer may be, I think this lease space talks about maybe a lab, another medical service, not another provider that's going to bill under a different number when they're in your space. Your cost report preparer may feel differently about it, so you want to check with them because there are all shades of gray on this. Bringing in specialists to answer Kate's question. The absolute cleanest way to bring a specialist into your RHC is for them to become RHC providers when they are working in your clinic. That way, everything is super clean. You're paying them a per diem or you're paying them a monthly rate to provide that service in your clinic, and you're able to bill their visits as RHC encounters. That is the absolute cleanest way. There's absolutely no issues of co-location or commingling. The next best way is to have specialists in non-RHC space or in the clinic during non-RHC hours. The least preferred way is to have them rent or lease exam room space in the RHC during RHC hours. We have never recommended this bottom one. I do know there are people that do them. There are people that have had relationships with other providers for 10, 15, 20 years, and this is the way that they've always done it. CMS has changed their opinion on these arrangements over the years, and they have a QSO memo, particularly dealing with hospitals and co-located space. So again, the cleanest way is you pay them and their services are billed as RHC services. The next best way is to have them in non-RHC space or in non-RHC hours. We were in a clinic last week. The clinic was designed so that it could have a hallway that was walk-ins. They ended up not using that. That hallway is completely separate from the rest of their clinic, and they are now leasing that area to specialists. That's fine. That's completely designated space. That's non-RHC space. So that will work. If you are considering an arrangement where you have somebody come in and lease or rent space during your RHC hours, absolutely do not do it until you talk to your cost report preparer or your consultant to make sure that you're doing it in a way that is not going to come back on you. So that's very important. I'm about to wrap up really quickly here. There's been a lot of discussion about incident to billing. So incident to billing is something that we see in the fee-for-service world because all of our qualified RHC providers can bill an encounter, and we are reimbursed the same amount by Medicare and Louisiana Medicaid for that service. There's absolutely no reason for our advanced practice providers to be billing under a supervising physician. Usually when we see this happen, it's because we have not credentialed those providers individually. They don't have their own NPI numbers. We haven't credentialed them. Some insurance payers 15 years ago would not credential a nurse practitioner. Almost all of them will now. And so it's not necessary in a rural health clinic. RHC for Medicare and Medicaid recognizes qualified providers. On the medical side, our physician, our MP, our PA, our certified nurse midwife. On our behavioral health side, our clinical psychologist, our LCSW, our licensed professional counselor, our marriage and family therapist, everybody gets paid the same encounter rate. So that is the beauty about being in an RHC. So we really don't want to report anybody under the supervising physician. Now, sometimes people will do it because they don't want to buy extra licenses for their EHR product. There's that pretty lady back on the screen.
Hello. Can you speak to the ability or inability for an RHC in Louisiana to provide dental care and also PT, OT, ST services for Medicaid patients? And then what are the potential problems around that?
Okay, that's great. Let me just finish with this one slide and I will circle back around because that's a really hot topic in Louisiana. So again, we shouldn't be billing under the supervising physician. If we bill incident to the supervising physician, it has to be an established patient with an established problem. All the APP is doing is following the original treatment plan for that already established problem, and the physician is on site. If we are not meeting all those 4 conditions, I can't bill incident to a physician even if I want to. That would be fraudulent. So our advanced practice providers cannot exercise any independent decision making and bill incident to the physician. So that's kind of where the rubber meets the road on that. Okay. Novitas has a decision tree on their page as far as if you think you're wondering if you do have an incident to service or not. And then CMS has some incident to guidelines. Again, all of this is found on the Novitas website. Okay. All right. I just cut and pasted it straight from there. Okay, before I talk about locums, let's circle back around. So for Louisiana Medicaid, I am allowed to have a medical visit, a mental health visit, and a dental visit on the same day for Medicaid. Those claims go in separately with separate codes. So I can have dental, I can have a medical visit, I can have a mental health visit, all on the same day for Medicaid, 3 different claims. The problem we find with dentists is first finding them to work in our clinic. And secondly, when we outfit an exam room for a dental room, we are obligating ourselves to dedicated space that's pretty expensive to build out. So you would want to do a feasibility study and make sure you were going to have the volumes of particularly Medicaid children to make sure that you're going to be able to support a dental service. I have talked to 2 provider-based clinics this year that started dental and decided not to run them through their rural health clinic. So you're just going to have to figure out if your space works, if your population is going to support the volumes you need for those dental services, but we certainly can do dental services. Just this year, LDH did send out an information bulletin that says we can do PT and OT in the rural health clinic, that is a qualified other service. It is not on the Medicare side. It is only on the Medicaid side. And so we still have a lot of questions because that provider is going to have to be someone who is enrolled as a Medicaid provider. And so right now we're a little unclear on using PTAs and assistance, therapy assistance, or whether that service has to be delivered by a physical therapist or by an occupational therapist. But those are standalone payable encounters. Some people have had credentialing issues with the Healthy Louisiana plans on them recognizing these as RHC providers. Some of our managed Medicaid plans are also giving us trouble with credentialing counselors and marriage and family therapists. We are already approved for those services federally and at the state level, so you should not be being asked to jump through extra hoops to credential those folks. So hopefully that answered that question.
Yeah, and then just to clarify, Patty, you mentioned physical therapy, occupational therapy. Is speech therapy included as well?
Yes, speech language therapy as well.
Okay, great.
I just don't see that as often. Yes. Which are great. We need those in rural, right? We're so excited to see those. Now, those visits are Medicaid visits. They can't be Medicare visits. So again, you're going to have to keep up with your visits and let your cost report preparer know so that they have different ways of reporting those visits on the different cost reports. So all the time we get asked, I have a nurse practitioner, she's going to be out on maternity leave, or I have a nurse practitioner and he's being called for National Guard, whatever the situation is. The only providers that we can substitute locum tenens, now they're called substitute or reciprocal providers, we can only use those for physicians and physical therapists. So the staffing companies will not always be honest with you about that. We cannot use a locum tenens for a nurse practitioner. So that is not allowed by CMS and most of the commercial. And that comes from, this is a different Medicare manual that comes from, and it talks about that it's only physicians and physical therapists that we can use a reciprocal provider. And this actually comes from Palmetto, which is not our MAC, but all MACs follow the same rules.
All right, so this is Medicare Advantage. So we've tried with certain MA plans and have been told that they are contracting primary care providers in the area. Should we be saying something specifically so that we can see these patients? They aren't wanting to change their PCPs and the insurance plan is beneficial for them.
Oh my goodness. So the wonderful Medicare disadvantage plans. So I have the very strong opinions. It's a good thing I only have 5 minutes left because I have very strong opinions about Medicare disadvantage plans. So the first thing you have to realize is that they are not Medicare at all, but your patient probably thinks that they are because they've probably been misled to think that they are getting a super duper better Medicare plan. So from our perspective, they are commercial plans. However, a Medicare Part C provider, which is what the Advantage plans are, cannot pay a Medicare provider less than traditional Medicare would have paid them. We don't have really recent documentation on this. We have a memo from 2007, which I have a copy of that sometimes we have to send. So you really want to be able to get a contract with those plans that recognizes your rural health clinic rate and will follow the RHC billing rules. These are getting harder to arrange. So you need to stand your ground and say, I'm an RHC, I get paid X amount. The Medicaid plans have to honor your Medicaid rate. So the Medicare Advantage plans should also honor your RHC contract. So you need to stand your ground and try to get an RHC contract. Don't give the thing that they send you. Don't just stay with the regular contract is what I'm trying to say. Also, they are supposed to build network sufficiency and then sell the plan in your area. This is something that CMS is slapping their hands for. They're being really tricky. They're going in and selling the market and then coming to you and saying, well, we just signed up half of your clients, half of your patients, and now we need you to enroll as a provider. It is supposed to be the other way around. They are supposed to build network sufficiency and then sell the product. So they are coloring outside the lines on that. So open enrollment just ended. Next year when it's open enrollment, you can get information out to your patients to tell them the pros and cons of the plans. You can't steer them to or away from a particular plan, but you can do the education that they're not getting from that salesman who called them on the phone. So
yeah. If I can just jump in with a couple
go right ahead.
So we have, if you go to our website, we did a webinar earlier this year around some strategies for negotiating your Medicare Advantage contracts and some of the leverage that you have as a provider they have to have network adequacy and those sorts of things. So if you go to our webinar recordings page, there's a webinar there that might help you with some tactics in that negotiating that contract with the MA plans. And also some of the AHECs have patient navigators where they can help your patients in the open enrollment process of getting on the plan so they can provide really hands-on services for those patients to get them on the right health insurance plan. So that may be something you want to take advantage of.
I forgot about that. Those are excellent services and they are no cost to your patient.
Yeah, they're no cost, they're grant funded. So
and they know all the ins and outs and they know how to tell the truth from the lies. So a lot of things, again, I'm not going to tell you what you can't do in your RHC. I'm just going to tell you if it is not a covered Medicare or Medicaid service, you really can't do it correctly as an RHC service in RHC space. And it doesn't matter if it's cash pay, if it's commercial patients, the patients don't count because we get the visits on the cost report regardless across all financial classes. So it really is just keeping up with those expenses and using our licensed space correctly. In Louisiana, the fact that our RHCs are licensed puts an extra burden on us, things that we can do in other states we can't do in Louisiana because of the licensure. And LDH is very fussy about licensed space and how it's used. So we really, again, consult somebody before you decide to do something. If you have a question or situation that you want to ask me about that you didn't want to ask on the webinar, here is my cell phone. Here is my email. Most of you already have it. And so just reach out to me if there's something you want to talk about that we need to cover outside of the webinar. Thank you, Danae, for this opportunity. I feel like I stumbled over my words a good bit today, but it's a complicated topic, but it's a hot topic, and we just need to stay informed, and that's what LRHA does for all of our rural clinics and rural hospitals.
Yeah. Do you have to run? We do have 2 more questions if you have time to hang on just a.
Oh, no, I'm fine. I just want to be sensitive to everybody else's time. I can stay here as long as you need me to.
Yeah, so we'll go ahead and answer these last 2 questions that are already in. So when trying to contract with plans, should we try under the RHC information or the RHC and the supervising provider, PA and PI?
So there are a few cases, and it's in the Louisiana Medicaid RHC handbook will tell you there are a few services that will be billable under the individual provider if they are not an RHC service and not a qualified other service. I would suggest, contracting under your tax ID, under your RHC NPI, if you can. I just find it to be easier. Independent clinics, we always have this argument going on between consultants about whether I need 1 NPI or 2 NPIs. In Louisiana, we do fine with 1 NPI with 2 taxonomies attached to it. In other states, it is more advantageous to have 2 different NPI numbers. So when we start contracting with some one way and some the other way, we can have problems with secondary claims crossing over. And then is that money, where is that revenue going to be attributed to? Is there something in those contracts that say if something is payable to an individual provider, how are we going to deal with that revenue? How are we going to deal with those costs and those visits? So again, a question for your cost report preparer going into it. I just like to push for RH, and I want to say this, and Danae probably agrees with me. Do not stop with the first no you get.
Yes.
The first person that answers that 1-800 phone call or gives you that first email response has only worked there a few weeks. They were working at 7-Eleven 6 months ago. So you have to push to get to somebody who knows about RHCs. They're not going to know that an RHC is a facility. They may not know anything about rural health clinics. We also have, LDH has a liaison between the clinics and the managed Medicaid plans, Whitney Martinez. You can send something to her. Once she brings it to a Healthy Louisiana plan's attention, they have 48 hours to respond to you and resolve that. So we do have ways to get above the fray, and don't push back. Don't accept the first no and go home, because they're wrong a lot of times.
So. Yeah, especially if you know that that's not what the rule says, keep pushing until you get someone who knows more information, because the frontline folks, they have a script, they don't have the depth of knowledge. And that's something, sometimes if you can't quite get to the right person, sometimes that's something that LRHA can help with, or even the State Office of Rural Health sometimes can help with, is getting the right person on the phone or in the email chain. Um,
Correct. And one of us could help you word something if you don't quite know how to word it in a response to them. Most of us will help you word something if you want to send it. So
Yeah. So for IOP services in an RHC, we've been told that you can't claim this on the cost report. Would it be better to offer these services during non-RHC hours?
So, um, so that's a great question. So yes, so the IOP is one of those things where you're paid a per diem rate. So it's not your all-inclusive rate. So that's our giveaway, that if we're paid differently than our all-inclusive rate, then it's a carve out. And IOP is very intensive. It uses a lot of resources and typically a lot of space. I don't know of any rural health clinics. We work in over 20 states. I don't know any RHC that is doing an IOP during RHC hours, just because logistically it's very difficult to manage. Um, but we can do it. We're allowed to do it, and we even have been increased to the number of units that are billable. So we can do it. It's needed. So IOP is a very structured, intensive outpatient mental health program. And it's always on the OIG watch list. It's known to be fraught with fraud and abuse. So you need to make sure that you know how to do it correctly if you're going to start it. It's a wonderful service. It's a lot more than going to Walmart and rounding up people and giving them donuts and coffee and letting them do arts and crafts, which was the trend about 20 years ago. And so um, if it depends on your space, back to the question, it depends on the space you have available, how that's going to interfere with your productivity of your clinic, because that is going to be carved out. Um, and so, again, that's going to be a case by case decision. I personally don't have any rural health clinics that are doing an IOP right now. If you're doing one, be glad for you to share your experience.
Yeah. And then the last question we'll do you know offhand, if there are plans that aren't following the LDH credentialing rules? Do you know who the contact person is for reporting offhand?
Okay, so that's great. So yeah, for RHCs, we are supposed to have expedited credentialing with all of the Healthy Louisiana plans. There is an informational bulletin, and it's law. If you know it, jump in for me on that information bulletin.
I thought I remembered seeing one, but I'd have to go look it up.
Um, so actually, our instructions from LDH are to reference the law in the subject header of the email and cut and paste part of that memo. Seeing if I can find that memo. Um, Jeff, if you can find it, you can pop it in the chat box.
Someone said Act 143.
Uh, I thought it was a four something, but maybe TH. There's only four that have it. Hold on, I'm going to find it for us really quickly. This information bulletin section, if you're not getting the emails on that, you really need to go out and check for those. Okay,
The expedited time frame, is there and do you know what an expectation should be in terms of the
I
time?
think they're Shelly's raising her hand. Did you find it, Shelly? That would be great. Um,
Yes, I found it. It's LARS 46:460.61, but it does say it's amended by Act 143 of the 2022 regular session.
okay, all right. Did you find the memo on it or
I didn't
just
find the memo. I This one was on the AmeriHealth Caritas website. But it
okay?
just says any provider who maintains hospital privileges or is a member of a hospital medical staff with a hospital licensed in accordance with the hospital licensing law, and it does that. Um, it tells you that you can refer to that.
Right. Okay. I did find the bulletin. It is Information Bulletin 23-18. And it does say in your subject line, put Act 143. So if you're having credentialing issues, because again, that frontline staff may be clueless about this. They may have been hired after this happened. And
And
so that
who
bulletin,
did they send the email to, Patty?
let me
Is it in the informational bulletin?
It is in the informational bulletin. Let me drop it in the chat. I'm seeing Q and O chat. Sorry, I was fumbly. There we go. There we go. And that's the memo. And it talks about how to address those plans. Again, I mean, it is exactly what we heard, unfortunately, last week. It is delay, deny, depose. So the longer everybody can hold on to their money, the better for them. But we need the money. So there it is.
All right. Well, good. Well,
Okay.
that's we'll wrap it there. I know we're over time, Patty. I appreciate you hanging on an extra few minutes to answer those questions. And thanks so much, everyone, for joining us today. As a reminder, as you exit, you'll get a survey. Please do take that survey. It helps us to improve future sessions. The recording and the slides will be on our website within 2 to 3 business days, usually. And as always, please feel free to reach out to us at LRHA if we can be of any assistance. And thanks so much and have a wonderful day.
Bye now.
Bye, everyone.